Good afternoon. We have all the panelists here, I think. So we are ready for live case and lecture number 11, Complex TAVR. I am David Cohen from Cardiovascular Research Foundation in St. Francis Hospital in New York, and my co-moderator needs very little introduction, S.J. Park from Asan Medical Center here. And we have two cases coming up from Asan Medical Center. Do you want to introduce our panel or go right to the cases?
All right, so we're going to start. You're going to explain that one. Right?
I explain what?
Okay, you're going to do that, right? So, Jung-Min and Duk-Woo, would you ready? Are you ready, bro?
Hello. Hi,
Hello,
Jung-Min.
Can you hear me?
Yes, we hear you fine. It's David Cohen and S.J. Coming to you from the Convention Center, and welcome.
Okay, good afternoon, Dave and S.J. Park. So this session we prepared a very complex TAVR case. My case is a TAVR in TAVR. The Park case is the TAVR in SAVR. So I'd like to introduce my team. This is Yeonwoo and Suyan-An, my junior colleagues. Dr. Suyan-An will introduce our case.
Thank you for your introduction, Professor An. We have an 81-year-old gentleman with a history of TAVR. He was admitted for dyspnea and exertion with NIHA functional class 2. He had previous TAVR procedure performed back in 2015 for severe aortic stenosis with a bicuspid aortic valve with Sievert's type 0 using 26 millimeter Valvular core valve. And the patient has Parkinson's disease. Next. And the patient was on medication for diabetes, hypertension, hyperlipidemia, and the STS score was 2.6%. Next. Electrocardiogram show normal sinus rhythm with a heart rate of 65 beats per minute. Next. Chest X-ray showed cardiomegaly without signs of any congestion. Next. Next. Transthoracic echocardiogram showed normal systolic function of LV, and you can see the shadow of previously implanted prosthetic valve in the aortic valve. Next. And the parasternal short axis view shows a severely limited motion of aortic valve leaflet with heavy calcification, and there's trivial aortic regurgitation. Next. Ethical four-chamber view shows normal biventricle function without pericardial effusion. Next. And color Doppler shows there's a flow acceleration across the aortic valve, and peak gradient was 119 millimeter mercury, and transaortic maximal velocity was 5.4 meter per second, and effective orifice area was 0.54 centimeter square. Next. And TEE confirmed the findings of prosthetic failure with severely limited motion of aortic valve leaflet. Next. And this is the image from the previous procedure, and you can see the patient had dilated ascending aorta and very spacious sinus area. And the Valvular core valve, 26 millimeter, seemed to be underexpanded. Next. And we measured the area and diameter at each level of the evolute R node, and this is node 6, which is a neo-skirt plane. The area was 372.2 millimeters square, and mean diameter was 22 millimeter. Next. And we did the same measurement for each level. Next. And there's a left coronary artery coming out at the level of node 4 to node 3. Next. Next. And coronary height on the left side was 12.9 millimeter, on the right side 18 millimeter. Next. And we have enough space, valve to coronary artery diameter were large enough, and there's little chance of coronary obstruction. Next. And this is a coplanar view. Next. And we have a large diameter of femoral artery for 14 French sheaths. Next. And this is a sizing chart for Sapien 3 Ultra. Next. This is the oversizing graph for 23 millimeter Sapien 3 Ultra. Next. And on the left, you can see the diagram for acceptable level of neo-skirt plane, which is node 6 to node 4. With high implantation, you have a chance of limiting the hemodynamics, and there's a higher risk of migration. And with lower implantation, there's too much left lobe overhang. Next. And on the right side, you can see the 26 millimeter evolute R reference diameter. Next. And we are targeting for node 6, and this is the expected overhang for each level of implantation. Next. And this is our plan for today. We're going to redo TAVR in 26 millimeter evolute R core valve using 23 millimeter Sapien 3 Ultra with -1 cc underfield, oversized plus 2.7%, and our exercise is from right femoral artery. And we'll predilate the valve with 18 millimeter balloon. And coronary angiogram was already done, showing a mild coronary disease, and there's no need for coronary protection.
Thank you, Dr. An. So do you have any question on comment on patient history?
So this is a 10-year-old
Yeah.
original core valve? It seems
Yeah,
that
right.
it's unusual to, so you treated him with a core valve in 2000, or somebody treated him in 2015 when he was 71 years old with a bicuspid valve. Was that normal at that time in Korea?
Frankly speaking, this patient transferred from the other hospital, so this is originally not our hospital, not our patient, but this is not the usual care regarding. Look at there are a lot of calcification around the aortic valve complex and bicuspid, and ascending aorta looks a little bit increased. So 71-year-old, considering 71-year-old and bicuspid, very calcified aortic valve. So I would like to transfer patient for surgery. But anyway, the 10 years later is a valve failure. So recently we implanted more than 2,000 TAVR valve so far. So nowadays we met more frequently than before. We met the TAVR valve failure. So far in our hospital, 18 cases of TAVR valve failures. 1/3 is related with infective endocarditis. 2/3 is related with valve failure. So instance is around 1% so far.
Are there other questions from the panel? Dr. Hung?
Actually, look at the angiogram is anyhow in the bicuspid valve, and the evolute R is the time between the initial implantation and the recurrence, and 10 years the maintenance is reasonable. And another educational case is when we do the analyze the morphology in the CT, is still eccentric appearance. And now we're focusing on the additional device before the procedure, we have to understand how do we expand the morphology of the valve. First, the original valve makes a more circular rather than and finally, this is some look at some natural history of a type 0 bicuspid valve, 71 years old, and the 10 years, quite a reasonable result. But at that time, surgery is maybe a best option for this patient.
If he came in today at age 71 with a bicuspid like that, I think, is there, I mean, this is not, necessarily so relevant, but is there anyone here around the table who, if this patient came at age 71 with a type 0 bicuspid, would be thinking TAVR first? So perhaps there was some extenuating circumstance at that time, but I think it's a very interesting case. It looks like you have very, you're lucky that you have very large sinuses, and so coronary obstruction isn't a big issue. Is there a commissural alignment here, just offhand? Did anybody notice on the CT?
So we previously checked the coronary angiogram, but it failed to through the strut. So outside of valve, the coronary catheter engaged the outside of valve.
So you
Not
passed
inside.
you passed around the outside of the core valve
Yeah.
to get to the left coronary.
Yeah.
Yeah.
Right.
Well, so I'm trying to think I guess you'll just go back the same way if you have to ever again.
It's interesting. The valve now seems to be more expanded than when it was originally implanted. Right?
Is this just different projection? It does look a lot more
Yeah,
expanded.
I mean, I suppose it's self-expanding and all that, but perhaps a different projection. But I think this case, the critical point is clearly not coronary obstruction, and we need to work out exactly where to place it to potentially give us the best circularity and gradient. And I think the proposed plan is probably worth discussing, isn't it? There's note 5 and 6, and Jung-Min, I think note 6 seems like the best option, you think, or?
Did you debate any other heights other than 6? I mean, you don't have a big issue with coronary obstruction, so you can take the leaflets,
right.
Go all the way to the top of the neoskirt.
In the fluoroscopic the appearance, the calcium is very heavier, especially in the non-coronary cusp. The calcium is such like some protruding. It's too much aggressive about the sapien valve expansion, maybe penetrate the population. So I worry about the severe burden outside of the calcium outside of the valve. So please
So
cautious. Yes.
you're worried you may not be able to fully expand the 23 sapien?
Yeah.
You're going to pre-dilate with an 18. I guess
Yeah.
we'll see. It seems reasonable to me. I mean, I think you'll get it. But I mean, it is very hard with these self-expanding valves. Or I mean, in a bicuspid type 0, getting it circular is pretty impossible, I think.
The 23 is okay.
Say again?
I mean, 23 is
23
okay.
is good. Yeah, I mean,
Just aim the neoskirt height below the coronary takeoff. I think we don't care too much about the nose, and also we don't care much about the lift overhang, because there has been no strong evidence showing that there is significant hemodynamic consequences.
so if they go at node 6, there shouldn't be any overhang, though.
Yeah.
That's as high as it goes. So, but you're right. I think that we used to worry about overhang, but it seems like it's less of an issue.
Dr.
Any other
since
pressing
this-
comments? Yes,
This
one?
is the case of the TAVR in TAVR. Would you want to implant the cerebral protection device in this case?
So are you saying you would? Are you going to, Jung-Min? Is that available for you?
Not this case, actually. Yes, TAVR in TAVR would be the high risk of cerebral embolization, but even though we don't have the scientific evidence, in addition, the patient have to pay the cerebral protection. So regarding the cost and clinical evidence, we don't insert the cerebral protection device.
Do you use them at all in your practice, or almost never?
Almost never.
But I think this kind of cases need the cerebral protection. The current scientific data is from the native valve, not the VBI. And personal experience in this kind of the BBI and the cerebral protection, the material itself is totally different. What I mean is a native valve is that the material itself is a calcium, but in this kind of the valve is a tissue material, big size of it. So if some of it is a really disaster. So there is no scientific evidence, but I think we have to be cautious.
We have we're presenting some data at the upcoming New York Valves, looking at the amount of material that's obtained treating valve and valve. So you'll see that coming up.
Does everybody agree with the predilatation without cerebral protection device?
Well, there
Because
certainly
we
isn't any
more
evidence.
modify the left fit, maybe more risk of.
I think in the U.S. many people would still think to use it, but I think here, when the patient has to pay out of pocket, that's and you can't tell them there's any proven benefit. That's a hard sell.
In your practice, as you usually do.
We used to do it all the time, and then we saw 2 randomized trials with no evidence of real benefit, and so we stopped using it routinely. We use it, very selectively, heavily calcified bicuspid, which this sort of is, and valve is another area where we would use it in our practice, but for native, normal native valves, no longer. Well, let's go. Why don't you go get to work, Jung-Min?
Yes, as always, the problem is cross the valve.
Yeah.
Crossing the wire to the valve. So it takes a long time, so more than around 30 minutes. Dr. Choi did it, failed. I did it for 20 minutes. Finally, we insert wire. Next, please.
Okay.
Yeah, these sometimes can be
insert
very
wire.
hard to cross with, especially the
Next,
core valves.
please.
It's with the tall leaflets.
Yeah.
There you go.
Next, please. So finally, successful to insert the wire because the Vmax is more than 5. Based on the CT scan, the very huge calcification in the top valve. So that is why
Sometimes in really tough cases of these, we've had to go antegrade. We've had to, do a transeptal and snare the wire, which is your final secret weapon.
I don't like to do that during the live demonstration.
I don't want you to. I'm glad you were able to cross.
Correct.
So
you're going to pre-dilate that, or are you going to measure hemodynamics
Yeah.
first?
yeah,
No hemodynamics.
pre-dilate.
Okay.
We already measured the hemodynamics.
Oh, okay.
So this is a balloon.
And this is just a standard Z-Med or Taishak, or I don't know what you use.
G-med balloon.
What size?
2018, I think he said.
18.
18. Pacing on. Inflation. Contrast. Deflation.
Perfect.
Pacing off.
Good to see the coronaries, Phil.
해주세요.
And the purpose of doing the predilation is largely to facilitate the TAVR valve crossing?
Yeah, facilitate. Yeah, right. Wire itself is very difficult to cross, so definitely we need the pre-dilatation.
And
Yeah, I think-
the second one is usually the pressure gradient more than 100 milligram, and when we deploy the valve, there is the chance of the valve migration in the
So you'd like to predilate for that as well? Makes sense.
It's even
Why
more important
keep
if
the
it's a
wire?
balloon expandable. I think if it's a balloon expandable valve as the index valve, you really need to expand it sometimes because 2 layers of metal, it's almost impossible to true balloon even afterwards sometimes.
So you're pointing out that if you want to have optimal expansion of the new valve, that predilating is important to prep the bed, just like with doing a calcified coronary lesion. And you said this is a 23 millimeter ultra? Do you have
Yeah,
ultra Resilia,
23.
or this is a standard ultra?
No, this is the ultra.
Okay. obviously these days we like to use the Ultra Resilia, especially in something like this where it's a smaller valve and we're worried about the gradients, but if it's not available, it's not available.
So in the valve and valve procedure, actually we don't need the contrast test during the valve implantation. So wire, keep the wire.
That's nice.
Okay. 네.
And so how are you going to make sure you get this to the level you want? Are you going to put the top at node 6?
Node 6. Actually, I'm very confused where is node 6, but I think around here
Okay.
it would be the
Very
node
low.
6. Yeah. Do you agree?
The one,
Please
two.
test.
I
gotta
think it
count.
would be the node. Yeah, node 6. I think. Anyway, test please.
I mean, if you get it at the bottom of the
Okay.
frame, it'll be at node 6.
Okay. Ready? Facing on. Inflation. Okay. Great. 1, 2, 3, 4, 5. Deflation.
Good.
Facing off. Oh yes, the Dr. Hong, your mention was right because I thrilled to see the dilation of previous aortic valve during the procedure, during the implantation.
Can you replay that for us when you have a chance?
Yeah. Replay. So upper margin,
Yeah.
usually
Wow.
the shortening occurred. Yeah, shortening occurred in the lower margin. Upper margin location didn't change too much.
Yeah, it really came from the bottom up.
Yes, I placed just the node 6 or something, and look at the outside the protrusion of the previous core valve.
You may have ended up at
but
node
I-
7, but I think it's fine.
Yeah. But even though the protrusion occurred in the above the calcification, the very native annulus and severe calcified annulus didn't enlarge too much.
Right.
So blood pressure looks fine. So I
Safe.
think I think that there is no perforation or aortic root injury or something like that. Anyway,
Will you post-dilate this or only if there's a significant gradient?
yeah. Anyway, I'd like to check the aortogram first.
Okay.
Ready?
Perfect.
Very nice.
Very good. That's great.
So I'd like to change to the remove the device and then change to the pigtail.
So we saw a very nice filling of the coronaries, so we're happy with that. This blood pressure is very happy. So I think we'll be pretty good. So you said this is the 18th or the 19th repeat TAVR you've done at your center?
19th actually.
19th now.
Median valve failure is 7.8 years.
Okay.
This is 10 years. Yeah.
So we're starting to see increasing numbers of valve-in-valve TAVRs, and I'm curious about everyone's center. So at my center, last year in 2024, out of 600 TAVRs, 5% were repeat TAVRs. Does anybody?
5%?
5% are repeats. Yep.
5% means 35.
Yeah, last year. So I think it's going to get more and more and more. We're doing so many more TAVRs than surgery, and treating younger patients who are going to live long enough. So I think we are getting there is a tidal wave that is coming at us, and we have to be ready with techniques and algorithms and useful apps to be able to know exactly how to treat all these different combinations.
Oh, pressure curve is very beautiful. There is no pressure gradient between the LV and aorta.
Very nice.
So aorta diastolic pressure is around 50. So I think the paravalvular leakage should be very negligible. So Dr. An will show you the echocardiogram.
Great.
Is there any change in the LV and diastolic pressure before and after TAVR?
What is the previous LV
And
diastolic
the
pressure?
diastolic pressure, EDP?
Before TAVR? Before TAVR, please show us that the before TAVR pressure curve.
So it's about 20 now.
Yes, 20 something. Just a moment. Could you show us? No paravalvular leakage on the echo.
We didn't. We got that went away very quickly for us.
So
That's
can you
baseline.
see the?
Yep, we see.
Yes, that it is baseline.
Yeah.
Baseline is also 20, 22. Yeah.
So it looked very similar.
Similar, very
Yeah.
similar before and after.
You're saying.
The and do we go back? Is the echo still being done, or is it all finished?
So okay, so I'd like to remove the wire, pigtail. So I'd like to show you the final, the aortogram. I'd like to finish my procedure, and then DW Park will prepare the more complex valve case.
All right.
Top-
Anyway, after
Top
final
peripheral.
aortogram.
Yeah. Let's see. They are a good aortogram.
Ready?
Perfect.
Very little. Very,
Very
very
nice.
little.
Yeah.
Great.
So it's a very, very nice result. Anybody want to do
Okay.
anything else other than high five and
Okay.
close the groin?
Yeah.
Good cases, Dr.
No, very, very
Alright.
beautiful
That-
result, Jung-Min. I think
Yeah.
Okay,
very
beautiful.
well. We're very well planned. I think that what we're learning, what we know, is that planning is the key to success in all TAVR procedures, but especially in these TAV and
Great.
TAV type of procedures. So
Okay.
Great.
Thank you.
Thank you so
Thank
much,
you,
Jung-Min.
David. Thank you, SJ.
Duk-Woo, can you hear me?
Okay,
Okay,
I can
can
hear
you-
you well. And okay, thank you for joining the complex TAVR case. And this is a session of a complex TAVR case. Our team thinking about the Jung-Min's case is very easy case compared to our case. Is our case much complex case. And welcome to David Cohen, S.J. Park, and Professor Myeong-Ki and Dr. In, and my friend Karl Poon. So I'd like to introduce our team. I'm D.W. Park from Asan Medical Center, and the Junghoon Lee is Eunpyeong St. Mary Hospital professor. He was our alumni, and the Han-Soo Park is our senior, the junior faculty. So, and Dr. Park, can you introduce the patient, the history and background?
Yes, Professor Park. I will introduce this case. Yes. This case is a 2-year-old female. She was admitted for near functional class 3 dyspnea. She underwent the surgical AVR. The valve was CE valve and size was 21 millimeter valve about 10 years ago. And then time after the SAVA, complete valvular was observed, so she underwent the permanent pacemaker implantation. Next. Her BMI was 26.5 and STS score was 8%. Next. EKG showed baseline rhythm was sinus rhythm. And next. And chest X-ray showed mild post-pulmonary congestion. And next. Echocardiography showed preserved LV function. Next. Insurance view showed the motion limitation of the previous prosthetic valve, and area was 0.59. Next. Ejection fraction was 70%. Next. Transaortic pressure gradient was about 57 and velocity was 6.8. After the dobutamine infusion, the pressure gradient was above the 100 and velocity was 5.0. Next. In CT analysis, neo-annulus diameter was about 19 and area was 283 and perimeter was about 16 millimeter. Next. And sinus to annulus ratio was 1.8 and ST junction to annulus area ratio was 2.3. Next. And LVOT area was 321. Next. Coronary height is so low. Left coronary artery height was about 4 and right coronary artery was about 5. Next. If we use the 23 millimeter valve to coronary distance was very narrow at the left coronary artery. Next. Left femoral artery is not visible because of the severe stenosis of common femoral artery, and right femoral artery is marginal because the iliac bifurcation chunks calcium. Next. In conventional peripheral angiography, show the right femoral artery is maybe possible. And next. If we use the SAPIEN valve, we can use the 20 millimeter valve. Next. And if we use the Everett Pro valve, we can use the 23 millimeter valve. Next. This is our plan.
Yeah, so this patient is a really complex case. 이제 coronary 그 distance 얼마 좁은지 보여줄까? So as you already show, the 82-year male and presented the dyspnea functional class 3 and 4, and relatively low flow, low gradient after dobutamine stress test, and Vmax increase up to 6.0, and mean gradient is nearly 60, and also anatomically very complex peripheral artery. There is some peripheral artery zone is calcium chunk. It's a very narrow 4.0. Is the access to peripheral is not easy. Also, coronary height and the VTC is quite low, and we absolutely consider the coronary risk of obstruction. Also, we consider patient processes mismatch. There are many considerations. So, this patient is most of TAVR company hesitate to input their valve. So I think absolutely not easy case, and the VTC very low, and prior CE the valve was 21, true ID is 19. So I think we have a lot of consideration, basilica or short core or peripheral, and there are many consideration. So and any suggestion from the comment from the moderator and the panel?
So the one thing I wouldn't do here, DW, is to fracture the valve. If you were thinking about that, you and I have had plenty of experience with that. But what I would be thinking of is a basilica. I mean, I would absolutely be thinking very hard about doing a basilica here with that low of a coronary, very little distance to the coronary. I would rather do a basilica than try, and a basilica in a surgical valve is one of the better basilicas you can do. Have you been doing them now? I didn't know if you had started to do them yet.
Yes, basilicas, frankly speaking, we don't have much experience, but we are very hesitation to do basilica. And I'm gonna do for this case of basilica, and I know some live case from the Western U.S. country. You are the U.S. interventionist nowadays use the shortcut. Is it David?
It's approved. But it's very expensive in the United States. It costs about $15,000, is my understanding. We do not have it.
$15,000.
Yeah, it's crazy. Everything is expensive in the United States. That's why we have all tariffs on everybody now. No, I'm just kidding about that. But we like to use a basilica We're very comfortable with it. We've done a lot. We have Jafar Khan, who's in our center, who's an expert in it, makes everything look easy. So I think if it's, that would be my recommendation. It certainly is not as expensive for us to do that. And we are looking forward in the United States. The other thing we are going to have, we think, very soon is something called the telltale wire, which is a special wire built for basilica that is insulated. It comes with some accessories that make it substantially easier, and it's going to be commercially available, I think, sometime, I don't know, maybe later this year, which will make it even a little bit easier. We've had good experience with that, but I think, I think this is a good case for it. It's not an easy procedure, but it's a good case for it.
So, and I think as a panelist, Karl and Dr. Ying and the Mao and the Professor Hong has a lot of experience with such a complex, surgical valve failure case. And any comment from the Dr. Ying and Karl? Yeah.
Well, I think basilica is a very good option.
I think that VTST is quite low.
Yeah.
So I think that for this case, I'd like to do the unicorn, but not the basilica, because we puncture the LCC defibrillator and the jet brake, and then implant a sapien valve, or implant the sapien valve and break the valve. Because the neoscale is quite high, so the VTST is still a problem.
The coronary obstruction mechanism here are twofold. The leaflet actually shutting down the left main and sinus sequestration. So your point of puncture has to be spot on, unlike if it's just sinus sequestration. As to whether unicorn's better, I can't comment on that. But I was going to ask David, in this case, if cost is not an issue, is a shortcut, do you think that's superior to basilica? Because I don't have that in Australia.
Well, I'm biased coming from the center that really believes a lot in basilica. I don't know if it's superior. It's everything I've seen about it is it's easier and probably quicker than a basilica. But I don't know that it's any better. Jaffer certainly thinks that it may not cut as well when there's a lot of calcium. I can't see a ton of calcium here, so I don't know what the mechanism of
That's what I thought. I mean, the basilica with a bit of ballooning, it really is a fairly well-practiced 30 minutes extra procedure.
I mean, you could also do a BA basilica where you balloon before you
I always do that. Every
slice.
basilica I do BA.
Okay.
I can't see the downside, perhaps.
Yeah. So, and I'm going to proceed the procedure, and considering the peripheral and the sapien is not impossible. Just it's a diameter is 4.0, and we're going to use the inline. We're going to should use the inline sheath, and for the valve. Okay. 잠깐만. This is a supply
Dr. Park,
wire.
do you intend to fracture the valve? Surgical valve?
No.
I think you get too close.
Fracture is absolutely. I think half of a panel in here remember a nightmare case 6 or 7 years ago. At that time, David and Professor Hong and Dr. Yin remember it's a coronary obstruction.
It was one of my favorite cases ever, DW. Are you kidding? The
Yeah,
2 hours
fracturing.
of trying to rescue
이게
the point.
잠깐만 요거 이제 그거 하고 잠깐 요거 잡고 있어봐 안 빠지게. Okay,
Dr.
so
Park, since we are concerned about the coronary obstruction and the basilica
absolutely.
procedure, so
Yeah.
can you show us the CT angel for the coronary alignment? Because it's important to do the basilica.
absolutely.
The alignment is good.
Yeah, that is very important. So, and our team, we don't have much experience about the basilica. We prepare the coronary protection, and then there would be some very high risk of coronary obstruction. We're gonna consider chimney stenting. We are already put the wire to the guiding catheter to the LAD, and then we will put this is the Megatron, the stent, and the 3.5, 24, and then. So, and the balloon, we try to do balloon is true ID is 19, and the balloon GMAD is 18. Sometimes surgical valve failure, valve passage is nearly impossible if we don't do any pre-dilation. So we just doing the pre-dilation and then check it up the aortogram and what happening in the during the balloon. We will check it up. 자, 들어갔나? 너무 들어갔나? 됐지? 자, 줌하고. 자, 여기서 한번 해볼게. 자, 천천히 준비됐지?
balloon.
잠깐만. 아주
With
천천히.
dilation.
자, 여기서 한번 보자. 자, pacing on. 오케이, inflate. Push, push, push. And the contrast. Okay, deflate. Okay.
What is size of the
pacing off.
balloon?
No.
This is 18 Gmet balloon.
Well, the coronary
So
filled.
I think you saw 요거 좀 봐봐.
During the balloon
You saw
inflation, anyway, coronary flow is
Yeah.
good, right?
Absolutely, that is good sign.
So you decided, I think I missed it in our discussion. So you decided not to do a basilica. Just, I mean, it's not something you're doing regularly.
We don't do basilica. You know, I think basilica is required a lot of experience and. At the time of the COVID-19, we are asked the live demo in the Dabir is from the Israel, and he has a nearly pioneer of the basilica. During the live case demo, it took 1.5 hours to do basilica. Yeah,
Was it a
it's
right
not
coronary?
easy.
Was it? I mean, left coronaries don't usually take that long.
Left coronary.
Huh, okay.
Yeah.
Right coronaries can be hard.
DBA is pioneer of the basilica, but even the DBA live case 1.5 hours to do is basilica live case demo.
I think that we're going to have to teach you how to do basilica sometime, DW, just because you're going to start needing to do it more and more. And so I think that is it's maybe shortcut will become available in Korea as well.
Yeah.
But there's just going to be so much,
Yeah.
down
Okay,
tab and
here,
tab.
and the first step is coronary assign, and the port is about 3 o'clock, and then first is peripheral. It's good. It's passed where, we're gonna now the inline sheath.
That is some beauty of the self-expandable valve.
Yeah, absolutely.
And second one is this case is really cautious. What is the low pressure, low gradient, and when I look at the echocardiogram, muscle mass be not thick, a little bit thinning. Is some worry about that, or what? Muscle mass is not so thick and usually in some hypertrophy. So in this kind of cases, too much manipulation is dangerous to this patient.
Absolutely.
One shot, one
so,
kill.
And at the time of the insertion and the great curvature, we make sure hand marker over there. And this is key step. And then lateral part is hand marker. Okay, over here. Okay, the stand. The Megatron is inserted over there. Okay, here. 자, 여기서 이제 들어가서 한번 그거 맞춰보자. 네네, 지금 한번 가보죠.
And the ducted part, would you intentionally to deploy at the lower part? The implant depth a bit deeper?
I would like normal position. Usually, inflow level would like the match the valve inflow level as well as prior surgical valve inflow level is usually targeting 3 millimeter lower. But if you do much deeper, there is some risk of a much hangover surgical valve is much overlap the coronary ostium. So we would like the normal position. So in the great curvature, we make sure over the hand mark. 오케이, 여기서 한번 저거나 살짝 풀어보자. 오케이, release. 오케이, release. 오케이, 천천히. release. 오케이, 천천히. 오케이, release.
More slowly.
천천히. 천천히. release.
The slower you can.
Would you pacing?
자, 여기서 페이싱 한번 해봐. 120 페이싱. 자, release. 혈압 떨어지면 얘기하고. release. 오케이, release. 오케이, release. 혈압 떨어지면 얘기해줘. release. 오케이, release. 오케이, release. 오케이, release. 오케이, release. 오케이, release. 더 빨리 release. release.
Yep.
release.
Pressure down.
좀 더 빨리 release. 더 릴리스 해야 돼.
More fast.
오케이, 더.
For such a patient with
혈압
slow
올라가지?
decline,
오케이.
Okay.
혈압 조금만 올려주세요.
Let's let them get deployed, and then we can discuss.
야. 혈압 이제 올라오죠? 오케이. 자, 페이싱 끄고. 오케이, 굿. 굿.
Waiting for a recovery of the hemodynamics.
Absolutely.
Yep.
Yeah, absolutely.
That's better.
You may want to go to a 2-1 view to just look at the left main, right? That's the other way
yeah,
to
absolutely.
look at the left main, left
자,
LA
혈압
cranial.
들어왔다. 자, 여기서 이제 we're gonna test the coronary ostium. 요 피그테일로 일단 여기서 자, 엔지오를 요걸로 한번 찍어 볼게. 에어토그램으로. 자, 풀샷.
Okay.
Yeah, I think it's good. And then 요 코로나리 쪽으로도 한번 찍어 볼게. 자, 여기서 자, 엔지오. Good.
Some intubation of the guiding catheter is more better.
Yeah, no matter. Absolutely. I think it's, position-wise, it looks good.
Yeah, there was a question here about whether you should deploy it lower, but I don't know.
No.
Was there any?
Yeah, it's, inflow level is the same. 여기서 한번 컷 뷰로 한번 가볼까?
I think it's too.
I think it's too high.
Yeah, because there's a -1.
So it's a depth of 1 maybe.
All right. Dr. I think we need a little bit, it's too much shallow. 1 or 2 millimeter more deeper. Actually, surgical device has already protected in some part of, sinus and coronary ostial part, and so you don't worry too much about it. And so a little bit, too much shallow.
I mean, if you go a millimeter or 2 deeper, she already has a pacemaker. There's not any.
Yeah,
so we need a little bit.
By recommendation of the Binibapa web, and usually we are trying to do inflow and just the 3 millimeter the prior the surgical valve. I think position.
You feel like you're at 3?
I think
any panel opinion?
Metallic rim is not the showing rim because showing rim should be 1 millimeter lower than the metallic rim.
Yeah. I mean, sometimes the enemy of good is perfect, but
okay, we can put one more time.
I think you can probably get it down
여기서
just a
에어토그램 한번
tiny bit
찍어보자.
lower. Yeah.
Okay.
It's reassuring that you have
깊게
good
들어가자.
coronary flow.
Okay. 다시. Okay, we're gonna deploy. 자, 빨리 감아. Okay, good. 쭉쭉 감아. 쭉쭉 감아. Okay.
2 millimeter more.
Okay, we try.
2.5.
Okay, great.
Okay.
Good.
That's great.
Okay, 계속 나오지? Okay. 자, 여기서 아까 또 그 커스 버블랩으로 가서.
And wait, recovery for the hemodynamic.
Yeah, absolutely. 자, 혈압 조금만 기다렸다가. Okay.
Alright.
오케이. 자, 여기서 내가 페이싱 하랄 때 하면 돼. 자, 여기서 한번 릴리즈.
This is the last trial.
Okay.
Whatever what it is, you have to release it.
야,
They'll get it.
천천히.
I'm confident.
릴리즈. 좀 천천히. 릴리즈. 자, 여기서 페이싱 한번 해봐. 120. 자, 릴리즈. 자, 릴리즈. 오케이, 릴리즈. Okay, release.
Pacing. More slowly.
Release. Now it's
When we
pacing.
release it, it's transmitted
Okay.
in the distal part. It takes a time.
I think it's much better.
좀 기다려. Okay.
It's definitely a
120
millimeter or
나오죠?
2 lower.
Release.
Much better than before.
Okay, release. Okay, release.
Good.
Okay, release. 자, 올려.
Pressure down.
Fast.
Okay.
Now fast.
더 빨리.
What do you think, David?
더 소리 날 때까지.
I think it's great.
Yeah, depth-wise.
자, 혈압 조금만 올려주세요.
I think it's perfect
자, 페이싱 스탑.
Depth-wise, I think it's a little bit better than before.
Right.
Yeah. No, I think
Okay. Yeah, we're gonna wait.
that was well done.
And we don't know yet. However, the surgical valve actually has already protected, sinus and coronary, ostial part, and so don't worry too
한번
much
더
about it.
찍어보자.
No, it's
Absolutely. You think about much differ compared to the previous 오케이.
No, not
자, 여기 한번
deeper.
찍어볼게.
I think it is.
I think now it's really good.
Yeah, no, I think it's the
Good.
depth is perfect. The
Yeah, good.
Good.
And then
I like it.
우리가 요 코로나리도 I think every audience and every panel moderator think about the Jung-Min's case of very easy case compared to we are very nervous. Company is very nervous. 그죠?
they make a good valve.
코로나리? Good, good.
Look at that.
Good.
Yeah, so I think position wise is good. So we're gonna try to do release over here finally.
More slowly.
Yeah, 한번 release.
More slowly.
It's, yeah, I like the tension release and the release. Okay, release,
More slowly.
release.
You can't go too
Okay,
slow. Is
release.
that the message?
Yeah, okay, tension release.
Right.
Okay,
Please.
Okay, release.
Still.
Okay, release. 더 조금만 더 빨리 해야 돼. Release. Yeah, Junghoon is frozen by MK Holmes' comment. Okay,
Great.
release.
It's almost there.
Okay, good. Release. Tension release. 더 이제 더 release 해야 돼. Okay, release. Okay, release. Okay, not yet. Release, not yet.
One's still on. There you go.
Okay, got it. Okay, at this moment it's very important, you know. Yeah. And then remove the wire. It's nose cone. We are very careful. Okay, got it. Okay. Okay, got it.
Nice.
And then 여기서 잠깐만. 이렇게 해서 자 이제 이거 빼고 자 천천히 같이 자 요거 시스 넣어야지. 자 같이 빼자. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3.
Although we don't want to perform the valve fracture, how do we think about the post dilatation?
Yes, you know, post dilation after checking of the flow the hemodynamics, there is no fresh gradient. We don't need require error.
I think we should, yeah, and we should definitely have an angiogram of the coronary to see if
This
there's
is
any
a time
evidence.
for
요거
determine the
한번.
balance between the more size or the risk of the
Yeah,
coronary
absolutely,
obstruction.
absolutely, yeah,
Yeah, coronary obstruction is worse than having the valve a little bit too small. I guarantee.
absolutely.
The position-wise is really perfect, right?
Yes, yes.
Right.
Yeah, no, I don't think you could put it.
Your TRIMI stenting will be provisional or intentional?
Absolutely. Is after checking of the angiography, there is some obstruction, and we do chimney, and without any obstruction, we don't need the chimney. Yeah. Okay. 됐지?
Any-
간다. This is okay. Good. Good. 이렇게 하고 코로나리 쪽 내버려두고 이걸로 한번 요거 빼고 다시 옆으로 볼게. 자, 테로모.
Your case is the really the high risk. It's more complex than the Dr. An's case.
Yeah, absolutely.
DW is going to earn his dinner tonight. I think he's going to.
Yeah, you remember our nightmare case, not easy, absolutely.
I also
It's
noticed
after
that
valve
in
fracture.
the memory book you didn't talk about that part of the case. You only talked about the fracture. You didn't
Yeah.
talk about the 2 hours we spent after the fracture rescuing the
요거?
coronary.
First of all, we're gonna show the pressure. 그거 하고 플러시 좀 다 해봐.
So that was very nice of you, DW.
오케이. 어떤 걸로 갈아야 돼?
If there's no coronary obstruction in this case, do you think
그렇지.
this demonstrates a limitation of CT prediction sometimes?
Well, CT prediction isn't about saying it's definitely going to obstruct. It's just saying it's high enough
Okay.
risk to consider doing something that you can do safely.
코로나리로 재지 말고
I think.
직접 이걸로 재.
It's going to be it's going to be very close. It's, no matter what,
플러시 다시 해.
it's not going to look
플러시
the way you
조금씩 다
want
해.
it. So I think that's for sure.
자, we will do flushing.
Gradient's pretty good.
한번
I think it's good enough,
pressure.
right?
Yeah.
Small
한번
difference.
flushing 해봐.
No air.
Okay, and then 됐고 또 another side.
Let's see.
Okay, 이제 프레셔 한번 켜봐. So, and this is hemo. Okay, 잠깐만 좀 들어갔나? 여기 LVJ. Okay, so I think hemodynamics is good, and the pressure gradient, and still some pressure gradient. I think
it's
yeah,
good.
Less, yeah,
82,
less than 10.
82 feet.
Yeah,
Yeah,
absolutely.
No, I think the
absolutely.
pressure gradient is okay. I think it's.
Yeah.
I want to see what
So,
the
and
coronary looks like. That's what I really want.
There is
Absolutely
some
good.
minimal pressure gradient.
Absolutely.
But
absolutely.
I'd like to let it alone.
이거 보자. So and the last remaining thing is coronary risk. We're gonna check it up. The coronary ostium is good, and then first and 우리가 요거는 이제 엘보 요거는 뺄게. 요거 저거. 이거는 빼고.
And you should do this at some point back. Make sure the guide is well backed out so that you have a good look at the ostium.
Because that's deceptive, isn't it? Your guide could be tenting the leaflet open, so you have to take it back.
Okay.
What about
자, 여기서 한번 찍어보자.
intravascular ultrasound?
준비됐지?
Do you think there's a role there, David?
푸샷.
Where's the
Then,
coronary?
자, 이제 코로나리 한번 또 여기서 여기 찍어보자. 자, 코로나리 한번 준비됐지? 자, 테스트.
It's okay.
Yeah, I mean it's filling. It just can't see it.
자, 테스트.
There you go.
Okay, we will check it up over here. 자, 찍어보자.
Angio.
푸샷.
Perfect.
It looks good.
Yeah. So I think it looks good, and the flow is okay. And then 요거를 스탠을 한번
Now
빼서
you
한번 찍어볼게.
do you? Where's your? Are you in the
There
ostium?
is no absolutely there was no limitation. 여기서
No,
한번 찍어보자. 오케이 테스트.
Okay.
자 여기서 한번 찍어볼게.
Back and forth.
조금 빼서.
Okay.
자 엔조. 푸샷.
Nice.
Yeah, yeah. So
It almost looks bigger than it did on the pre-op.
Yeah. So I think its coronary flow is okay, and the hemodynamics okay. I think this is the best result we can achieve. And absolutely the patient's condition and vital sign is great.
It's good.
So
Yeah, I think if you put a stent in, if you did a chimney or something like that, all that would do is make your life much more difficult if you ever had to come back again. So I definitely wouldn't do that.
Therefore,
Actually,
we usually do the guided rather than the stent. For the
okay, that is a good option.
What is the
absolutely,
destiny of the stent? Is a threshold is through the
Proceed.
Yeah.
Alright.
Okay, go ahead.
Procedure-wise, it's very simple.
excellent.
Yeah, well, I mean,
Doug, you really make a complex table here.
Absolutely.
Alright.
I'm very nervous.
Alright.
I have a nightmare with David Cohen.
wait a sec. It's still one of my favorite cases ever, DW. The patient came out great. We had a good time. But this is, I mean, I think what this shows is, you have to plan for the worst and hope for the best, right? That's what we do. So you are prepared for the most serious complication you could have. You've thought about all the different options. You have a stent in place. If you don't need it,
Absolutely.
terrific news.
Yeah. So I think this case is one of a typical complex case, and the reason why we require more tool like a shortcut or much user-friendly. Basilica is too much complex, not easy to apply in our real world. So such case is growing up. I think we require more advanced the tool like a shortcut anyway. So and this is I think a typical case of the complex TAVR case.
All right. So Doug, after the remove the coronary caster, and then finally we need a aortogram.
Absolutely. Yeah. Okay.
I think we
Okay, we want to see that. What's happened?
Okay. So
After
then remove. Yeah,
remove.
this guide caster is removed.
Okay,
then,
perfect. And
okay.
then finally,
요 와이어 조금만 넣고 체크 찍어보자. 자, 요거 엔조. 이 해머 에어토그램 준비됐지?
carefully.
자, 푸샷. Yeah, coronary flow is
I
good.
think it's perfect,
And
right?
we're gonna show the en-passe view how much well
No AR,
yeah.
no coronary obstruction.
Okay, over here.
It's great.
Near the en-passe view. Okay.
Nice.
Good.
Perfect.
Yeah,
Pretty
I think its coronary flow is good.
No, I think
there's
that's
no AR.
a beautiful job. Like I said, it's, you have to be prepared, but when everything goes well, it goes a lot quicker. So it's
Thank you.
a terrific result.
Okay.
Thank you so
Yeah.
much, DW. We'll see you soon.
Thank you.
Good
Thank you so
cases.
much.
Thank you.
잘 끝났다.
A simple question, David. Really matter of ppm, patient prosthetic mismatches. In the era of saver, right? It'll be higher frequency, and then the prognosis is not so good. However, TAVR is a little bit different, right? And the minute, what I'm asking is, before the TAVR procedure, surgeons choose the little bit smaller valve, right? Is it right?
Yeah,
All right,
but now I think the surgeons have been educated by TAVR and by the experience in the trials, and there
it's
is
getting
more,
bigger.
they're at least implanting a larger valve. There still isn't a ton of root enlargement going on because that's a more complicated procedure, but at least put in the biggest valve that you can, and I think they are doing a good job of that. And we now have, we have some valves like the Inspirus where you can expand it easier.
Particularly these cases, actually, annulus size is big and, root is big. However, size-wise, surgical valve is a relatively small one, and so.
Yeah, that's just common. This 21 millimeter Magna, which is what this patient had, is a very, very common valve. And again, fortunately, she's a smallish woman, and so that's not so small for her. But we see, even in the United States, with the big patients that we have, there's an awful lot of 21 Magnas and 21, even worse, some of the other valves that even have a smaller MLA. So this is beautiful. I think we are now ready for our featured lecture.
Right.
Is Professor Garot here?
Philippe,
there he is. Okay.
Garot will give us asymptomatic severe aortic stenosis, valvular disease, and therapies. Thank you for coming. Marie Claude de Maurice stores and so on. All right, good.
Thank you very much for the kind introduction, and thank you for this invitation to present asymptomatic aortic stenosis, valvular disease, and therapies in this great session with two fantastically executed live cases. These are my disclosures. So first of all, as you all know, the current guidelines support clinical surveillance for patients with asymptomatic severe aortic stenosis and normal left ventricular ejection fraction. We're going to discuss this in a few minutes with 4 randomized clinical trials. And first of all, the early TAVR trial that was recently presented by Philippe Généreux in Washington during TCT a few months ago. And you know that the objective of this trial was to determine the safety and efficacy of the strategy of early intervention with TAVR compared to clinical surveillance in patients with asymptomatic severe aortic stenosis. So the study design was a randomized clinical trial comparing transfemoral TAVR with SAPIEN 3 or SAPIEN 3 Ultra compared to clinical surveillance, and the primary endpoint was a composite of all-cause death, any stroke, or unplanned cardiovascular hospitalization at a minimum follow-up of 2 years. You can see that the primary endpoint was significant with a hazard ratio of 0.5. And most importantly, as you can see here, this was mainly driven by lower unplanned cardiovascular hospitalization in the arm, in the group of patients treated with TAVR compared to clinical surveillance. There was obviously no difference in terms of all-cause death, and just a trend without a significant difference in terms of stroke. And most importantly, you can see that this strategy was better compared to surveillance in all predefined subgroups, of course, gender, but also STS scores and ability to perform tests and severity of the JET, of the aortic stenosis. Second randomized clinical trial is the EVOLVE trial. This was published recently in JAMA, and as you can see, 224 patients with asymptomatic severe aortic stenosis and myocardial fibrosis, so advanced, asymptomatic aortic stenosis were randomized to early intervention with surgery, TAVR, or clinical surveillance. And the primary outcome in this trial was all-cause mortality or first unplanned aortic stenosis hospitalization. And this trial showed no difference between the two strategies without any significant advantage of early intervention in this trial. The third one is the AVATAR study. The objective of this study was to evaluate the safety and efficacy of early surgery in asymptomatic patients with severe aortic stenosis and normal LV ejection fraction. As you can see, 157 patients were randomized, 79 allocated to conservative management and 78 to early surgery. And AVATAR was positive with a slight significant difference in terms of all-cause death, acute myocardial infarction, stroke, a planned hospitalization for heart failure. And you can see that the log rank test was 0.02 and was also significant for all-cause death and heart failure hospitalization. And finally, the fourth randomized clinical trial was the recovery trial, comparing long-term clinical outcomes of early TAVR with those of patients with clinical surveillance. All these patients were asymptomatic. You can see that 145 patients were randomized, 73 had early surgery, and 72 had surveillance. And in this trial, the primary endpoint was operative mortality or death from cardiovascular cause, and there was a significant difference in terms of primary endpoint with early intervention compared to clinical surveillance. So if we look at all these four trials and the meta-analysis that was proposed by Philippe Généreux a few weeks ago during ACC and published a few days ago in JACC, you can see that we have 4 randomized clinical trials with 2 of them showing a high level of low-level stress test in most of the patients, meaning that these patients are really asymptomatic. And if you can see here, the results of these 4 trials, so 3 trials met the primary endpoint, of course, early TAVR, AVATAR, and recovery, but not evolved AS. And there was no difference in mortality in most of the trials. So if we look at this meta-analysis, you can see that there was a significant advantage of early TAVR in terms of heart failure hospitalization, unplanned cardiovascular and heart failure hospitalization and stroke, but not in terms of all-cause and cardiovascular mortality that was not significant with early intervention. We have recently published a meta-analysis with these 4 randomized clinical trials with 2 major, I would say, observational registries in asymptomatic patients with severe aortic stenosis. And what you can see here, that while adding these 2 large randomized observational registries, we add significant benefit of early intervention compared to clinical surveillance for both all-cause death and cardiovascular death, although it was not significant if we only focused on randomized clinical trials. So to conclude, current guidelines recommend routine clinical surveillance every 6 to 12 months in asymptomatic patients with severe aortic stenosis and normal ejection fraction. We have now 4 randomized clinical trials in these patients showing benefit of early intervention, either in reducing heart failure, hospitalization, or stroke. We have a recent meta-analysis pooling data of the 4 randomized clinical trials and 2 large observational studies showing a decreased incidence of all-cause death and cardiovascular death. And it's, in my opinion, the good moment to update current recommendations in these patients. Thank you.
So I think this is a good place to have a discussion about the guidelines and what your opinion is. Will they change? Should they change? So anybody want to weigh in? The guidelines currently don't recommend treating asymptomatic patients. Do they recommend surveillance? Dr. Poon, do you want to let us know your thoughts about whether is it time to change the guidelines? If so, how would you change them? What level of recommendation would you make for treatment of aortic stenosis in an asymptomatic patient? And would you make it different for surgery and TAVR?
Wow, David, that's a lot of questions.
That's all the questions I have, though.
Look, I think the evidence is mounting, isn't it? As you know, there's another, I think, 10 randomized controlled trials are looking at early intervention as well. We were involved in a few. I think certainly the evidence, observational or tier 1 randomized controlled trial data is there. So at the very least in the interim before it changes guideline, I think we need to do a better job, follow patients up a bit more, avoid acute valve syndrome a bit more so that they don't get sick. This 6-monthly review is probably not enough. In the background, in somewhere like Australia where we need to build up and scale up, I think we need to speak to our hospital administrators and whatnot to do more cases, right? I mean, this whole deluge of cases coming, it's going to be difficult. But to answer your question, I'm sure all of us would agree that it's probably time to look at the guideline, whether it's class 1 or 2A, that's debatable. Whether it applies to surgical, I think as I learned today, in Japan it's already asymptomatic severe can be operated on, but not so much in Australia, perhaps in the US and Europe either.
I can't remember what it says in the U.S. for. I think it might be a class 2A or something with for surgery because the guidelines were only updated in 2020, and the only trial that was available then was a recovery. So there was only one trial available when the last guidelines were updated. I mean, I do think. There are people who have looked at these data and said, well, look, we have 2 surgical trials, and you actually didn't even show the most recent updated results from Avatar, because Avatar, when you continue the follow-up out to 5 years, shows a mortality difference as well. And so we have 2 surgical trials that show a mortality difference, and then we have 2 trials, we have early TAVR, which showed no mortality difference at all, absolutely the same with TAVR, and then Evolved is a mix. It had both aortic and honestly, Evolved didn't even do their early TAVR very early. It was sort of late afternoon TAVR or something like that. For it, but I just want to push because there are some people who have looked at those data and said, well, surgery, we should do surgery in all these patients because that's the only one that saves lives. So, Philippe, what do you think about that? Do you think that's a proper interpretation of these data, or do you think that's some artifact?
No, I definitely think that the guidelines should be upgraded for both TAVR and SAVR because it's not a class effect. It's not about the therapy that we use. It's about the moment to treat the patient. And I really think that we have to think about intervention, and then we will talk about heart team, the role of heart team, the age of the patient, life expectancy, and all these things that we well know now. But once again, the problem is about when do you replace the valve in your patient? And what we know now from these trials, and just speaking about early intervention, we know that we are waiting too much for our patients because most of them, we know that there are many considerations about when to intervene, and it's about the waiting list, it's about everything. How do you do you do the surveillance of your patient? Do you do some echo once a year, twice a year, etc.? So I think it's really positive for the patients because we are going to think differently for this patient, not waiting for angina, not waiting for advanced dyspnea and all these things.
Yes, go ahead. We're almost out of time.
Thank you, Philippe. Should we further risk stratification for this asymptomatic patient, like the cardiac MRI, echo for the RV function, pulmonary hypertension, or some exercise test, submaximal or suboptimal? Thank you.
Absolutely. I think we should not wait for symptoms. We have to follow these patients very actively. What is very nice with the trials is that we had treadmill tests showing that the patients were really asymptomatic without any ECG changes and everything, meaning that even in these patients you had a benefit of early intervention. But I think really that we have to follow the gradient, follow LV function and everything, because if you wait too long, then you might have, a bad prognosis and more events. And we should not do that.
I mean, the one thing that was just presented at the ACC was there was a biomarker sub-study from early TAVR, which showed that the biomarkers, elevation of NT-proBNP and troponin, didn't really differentiate between patients who would benefit and patients who didn't. It really didn't seem to be all that helpful, although, again, they were prognostic. So the patients who had higher troponins in particular were more likely to die or have rehospitalization during follow-up. So I think it's a prognostic marker, but it doesn't really tell you when to treat for that. I think we are just about out of time. I think, and so I don't know if something else is coming, but I want to thank Dr. Garot for a beautiful talk, and obviously our friends and colleagues from Asan Medical Center for 2 wonderfully done cases. Thank you to the panel for a great discussion. Have a great afternoon.